Okay. So, is it? Can you see my screen?
Yes, sir. Good
Whole
morning.
screen.
Good afternoon, sir.
Good morning. Good afternoon. You can see the whole screen, eh? Or
Yes.
part of the screen.
Whole screen.
Whole screen you are able to see. Just a minute. So, yes. Fine. Okay.
Yes,
Fine.
sir.
So now you can see the part of the screen, right? And
Yes,
everything
sir.
is fine. And I'm audible. You can see the screen.
Yes.
So we are running 7 minutes delay. Okay. So welcome you all after a gap of maybe 2 weeks or 2 to 3 weeks. So this was basically met. एक मिनट why एक मिनट સચિન તું અહીંયા આવ ને જલ્દી બેટા હા હોસ્પિટલમાં છું જલ્દી આવ નીચે sorry for little inconvenience.
The recording will be available on Facebook or YouTube.
YouTube.
Yes.
It will be accessible for everybody on my channel.
Yes. Yes, sir.
I'm really sorry for little delay. YouTube. Hello, am I audible?
Yes, sir.
Okay, so let us start with the topic. So basically, today's topic was meant for a novice, those who are recently enter into infertility, or those who wish to, enter into infertility practice, and those who really want to learn how to make a correct decision, because correct decisions are very, very important. Because we all know the urine reserve is getting diminished very rapidly in Indian women. So kindly keep yourself mute unless you want to ask something, because in between I'm getting noise. Uh, so uh, that's the reason unnecessary delay should be avoided. And this approach or this presentation has been made absolutely on practical points, which is going to be very useful, I'm sure, in your day-to-day practice. So we will be concentrating basically on history, investigation, and treatment decision. Treatment decisions are very, very crucial, which patients requires what and when it requires what. So let us start with uh, so we all know, I'm not going to take details of the history and normal history and menstrual history and other things, but there is a special mention of dysmenorrhea, dyspareunia, and leukorrhea with the lower abdominal pain is must in all of your patients who are coming for the subfertility in your OPD, because that gives a very, very important clue about chronic PID, peritoneal disorder, adhesions, endometriosis, COX. So a lot of information you just it's given by the these three symptoms. And we all know in chronic PID, in peritoneal adhesions, in endometriosis, these symptoms are very, very common. And dyspareunia gives a fair idea that maybe the patient has got some inflammation of the pelvic support musculature, maybe in the form of PID, maybe in the form of endometriosis. Leukorrhea with the lower abdominal pain, maybe because of some local causes also, apart from the uterine disorder and peritoneal disorder. So the positive history of these three symptoms are very, very important. Apart from you're supposed to note whatever patient says, narrates or complains about her problem. Uh, in menstrual history, you must positively ask whether she is getting period earlier than a month or little later or at the time. So can she predict the cycle exactly on the same day? That is the question to be asked. Can she predict the cycle on the same day? Suppose she's getting on 7th. So next month she is going to get 6th or 7th, or maybe she will be getting on 3rd. Even 2 to 3 days or 4 days, only 2 to 3 days early menstruation or shorter cycle, 90% of such patient, if you look at the ovarian reserve, you will find out diminished ovarian reserve. The antral follicle count maybe 12, maybe 11, maybe less than 10. So this cycle pattern, short cycle, is very, very important, and that gives a very good idea about decreased ovarian reserve. And you all know short cycle is because of the shorter follicular phase. It is because of the early recruitment of the follicle. It is because raised basal LH, sorry, basal FSH level, and that is because of the uh, uh, early inhibition, negative feedback of the corpus luteum, and she start getting the corpus luteal defect, you can say, or shorter corpus luteal phase also. There is early recruitment of the follicle. Early late luteal rise of the FSH is little earlier, and that helps in recruiting the follicle. Apart from that, the irregular cycle also gives some idea about other hormonal disturbances like PCOS or maybe hypothyroidism. So regularity of the cycle is very, very important. Secondary amenorrhea, if patient has got secondary amenorrhea, that gives fair idea of severe PCOS or maybe some pituitary disorder. The heavy cycle gives idea about uterine problem like polyp or maybe fibroid, or maybe in sometime chronic PID also there is a heavy period. And scanty cycle gives some idea about intra endometrial adhesions or COGS or something like that. So that gives a fair idea. At least that you cannot clinch the diagnosis with history, either history or menstrual cycle pattern. But my intention is you must concentrate on these points. You must inquire about short cycle, irregular cycle, secondary amenorrhea, heavy cycle, and scanty cycle. So after taking the history, if you come to the examination, apart from all general examination and measuring blood pressure and everything, you must positively look for the hirsutism, the signs of extra hairs, especially on the chin, breast. You must, and overall, the hairiness of the body part, you must inquire or you must examine. And yeah, you must see for the galactorrhea in all patients. So me being a male gynecologist, I always, after examination, after doing transvaginal sonography, I always tell my assistant to check for, thoroughly check for the hirsutism and examination of the breast, and notify if any sort of discharge is there or not. So that patient is comfortable. And then, of course, we do a first speculum examination and PV examination. That gives a fair idea about the local lesions. And we all know nowadays vaginal health, vaginal disc biopsies is very important cause for infertility or implantation failure, you can say. So you must inquire about, we must inquire to get the idea, you must examine per speculum and for PV examination. Uh, Not only that, we can fair idea about the local cervical lesion like cervical erosion and polyp and other things. So after finishing the examination, we normally do a transvaginal sonography at first consultation. Now, if you're well versed in 3D sonography, then you must do 3D sonography, because 3D sonography gives a very good idea about the shape abnormality of the uterus and location of the fibroid, number of the fibroids and other things. So you must do 3D sonography. And if you're not expert in 3D, at least you should do good 2D transvaginal sonography. That give a very good idea about the pelvic organs, polyp, maybe intrauterine adhesions, maybe fibroid, location of the fibroid, whether it is disturbing the endometrium or not. How is the endometrium looking? How is the vascularity of the uterus? Is there any free fluid in the pouch of Douglas? Not only that, it gives a good idea about the architecture of the ovaries, the arrangement of the follicle, number of the follicle, antral follicle count, size of the follicle. You can examine antral follicle count anytime during the cycle, because there is a continuous recruitment of the follicle. There are different waves of follicular recruitment. So you ought to get an idea about the antral follicle count anytime. So you should not miss the opportunity of measuring antral follicle count anytime. After that, when you're doing transvaginal sonography, you should cultivate a habit of always look for hydrosulfings, because we all know sonographically detectable hydrosulfings. If it is there, then it must be treated, and possibly either salpingectomy or delinking should be done to improvise the implantation. So this patient require a laparoscopy later. So after doing transvaginal sonography, we advise certain basic lab investigation like TSH and prolactin, and not to forget the male partner semen analysis. And Normally, I advise AMH in all patients unless I find the ovarian disorder absolutely normal and the patient is young. Otherwise, in all patients, including PCOS, I advise AMH for the reason I will discuss later. So these are the basic investigation: TSH, prolactin semen analysis, and AMH. So, having said that, we have noticed the history, we have examined the patient, we have done transvaginal sonography, and we have advised certain investigation. So, in taking a decision, important decision, our emphasis should be put on the age of the patient for the reason we are going to discuss in the next slide. BMI is very important because this patient requires a gonadotropin or any drug, the dose calculation or dose requirement varies in different BMI patient. If the patient is obese, the dose requirement may be more, or if you go for certain investigations uh, uh, to judge the efficacy of the, say, for example, trigger, then the values may be less because of the dilutional effect. If the patient is obese, then it reduces the implantation rate. So BMI is very important. For example, patient is obese and PCOS, and if she loses little weight, probably the anovulation may be corrected if she loses 5 to 10% of the weight. Active unprotected sex life with the adequate frequency. What do you mean by adequate frequency? 3 to 4 times in a week. So if the active unprotected sex life is 1 year, if the age is less than 35 years, and if it is more than 6 months, if the age is more than 35 years, that's enough. That patient, even if she doesn't have any problem sonographically or maybe any having regular cycles, still she needs a further investigations and treatment. So you have to inquire this in detail. And last but not the least, the psychological and financial aspect of the couple regarding fast track treatment or the standard method of treatment in case is very important, especially in case of young people. So if you go by the book, then if the couple is young, then if you go by the evidence, it is suggested, okay, first try with the time intercourse. If that is not working, then you step up the treatment. If that is not working, you just step up, do further investigation, and as a last resort, you have to go for say should go for IVF. Now this is fine if the patient is okay with that, because nowadays in current scenario, all the patients they come quite late for the infertility treatment, and once they have decided, they have fixed timetable in their mind. They want to conceive within 3 months, 4 months, at the most 5, 6 months. So they are not going to be with you for a longer period. So you must understand the psychology of the patient or the couple and their financial aspect. Uh, if they want fast track treatment or they want a standard step up treatment, this important decision to be taken at first consultation only. Now there are I come across many couples who believes in fast track treatment. They do not want to waste the time uh, in a standard way. So it's like simple. Suppose somebody wants to travel, and if you ask that would you like to go by train or would you like to go by flight, and if the patient, if she's well affording and for her time is important, she will always tell, okay, I will go by flight only. So nothing wrong. I always discuss this aspect with the patient, and if the patient is okay with the faster treatment, then our way of treatment is different. And if the patient is asking for a standard way of treatment, then the treatment is different. But you must inquire and must discuss while you're counseling, following the first investigation, first consultation. Now, the issues to be addressed related to the age. We all know there is a age-related qualitative as well as quantitative decline in the ovarian disorder. Why there is a qualitative decline? Because that increase the age with the age, the chances of aneuploidy increases. If that patient conceives, there is increased chance of miscarriage, and if not miscarriage, that increases the chances of malformation. So overall, age plays a very, very important role. And Indian woman, after 24 years, you have to educate them that now your decline in the ovarian reserve, qualitative as well as quantitative, has been already started. Why there is a age related? How can you say that there is a age related quantitative decline also? Because if you observe, as the age advances, there is a reduced pool of primordial follicle. Of course, you cannot see the primordial follicle, but antral follicle count represents the pool of primordial follicle. So there is a reduced antral follicle count. There is a reduced recruitment of the follicle. There is a reduced follicle output rate. Normally, when there is antral follicle count, for example, say 10, and if you in full force, suppose you stimulate in IVF, I'm talking about IVF, then you should expect at least 7 to 8 follicle to grow. So follicle output rate is reduced with the age. There is increased gonadotropin requirement because HPE axis itself becomes aged, so it does not behave as it should behave. There are lesser number of the oocytes. Suppose you retrieved 7 follicle, you get only 5 oocytes, something like that. If there are lesser number of the embryos which are available per stimulation, and there is a long time to pregnancy. So these age-related issues should be discussed at first consultation only if the patient's age is more than 24, 25. And I'm sure our majority of the patients are between 25 to 35 only. So after discussion, first decision, or you can say the first most important thing is we should come to the provisional diagnosis of factor which is responsible. When you start discussing with the patient, at least you should have a fair idea in your mind from the history, examination, and transvaginal sonography that probably you are dealing with what? Is there any ovulatory disturbances, or it may be a male-related, semen-related problem, or some other sexual problem, or are you dealing with the ovarian reserve, or you found something abnormal while doing sonography in uterus and endometrial cavity, or you are dealing with the tubal problem if the tubal evaluation is already done before, or are you suspecting endometriosis, including the adenomyosis? And if you cannot find anything, then probably you're dealing with the unexplained infertility. I would say undiagnosed infertility. So we will go into little detail. How do you suspect ovulatory disturbances, semen-related problem, ovarian reserve-related problem, uterus-related problem, tubal problem, endometriosis-related problem, and nothing is found, then it is unexplained infertility. So how to assume that the patient may be having ovulatory disturbances? First is the irregularity in the cycle. Irregularity in the cycle clinches the diagnosis of the ovulatory disturbances. That does not mean that the cycles which are regular are always ovulatory. No, you are mistaken. Approximately 1 in 6 cycle or 7 cycle, maybe even in spite of regular, it is anovulatory cycle. So the first clue we get by irregularity in the cycle. Then as we do a sonography, we find PCOM, polycystic ovarian-like arrangement of the follicle morphologically. So we say it is a PCOM-like pattern. So that gives idea about the ovulatory disturbances. And when we get the report of hormonal analysis, we get the idea about the hypothyroidism, maybe hyperthyroidism, hyperprolactinemia, insulin resistance, hyperandrogenism, and hypo. So normally, as I discussed, we normally advise for TSH and prolactin. So that covers hypothyroid problem and prolactin problem. Now, insulin resistance, we are not testing in all patients, but if the patient is PCOS, then and obese especially, we'll discuss later in which patient we should advise testing of insulin resistance. And hyperandrogenism, when we have a clinical uh, uh, picture of hirsutism, then and hypo, if we are confused about whether patient has got secondary amenorrhea, and we are confused about between we want to differentiate between PCOM and hypo, because many times the sonographic picture is same in PCOS and hypo also. But in hypo, the size of the uterus is smaller. The PCOM like arrangement may be present in the ovary, but when we advise for FSH, LH, and E2, we can easily differentiate between PCOM and hypo. So these are certain clues how we can assume that patient may be having ovulatory disturbances. Now, how important is subclinical hypothyroidism in infertility women? But the results have been inconsistent. Different studies results are not consistent. But it has been observed that there is a slightly higher TSH level in the infertile woman compared to the control. So that is very important finding. And second important finding in one of the study, they observed that this subclinical borderline hypothyroidism, they empirically treated with a smaller dose of thyroxine, and approximately out of 94, 72 of them spontaneously conceived within 1 year. So probably subclinical hypothyroidism, if you treat with the smaller dose of thyroxine, there is no harm. It may help in conception. Uh, what about the prolactin level? So the prolactin level is normally 5 to 20 nanogram per ml, and if it is more than 250, then definitely it is suggestive of pituitary tumor. During measuring the prolactin, you must keep this in mind that it should be ideally measured in follicular phase. It should be measured early in the morning without any stimulation, without any sex, without any nipple stimulation, with after adequate sleep, because all these things affect the prolactin level. So you have to be very specific when you advise for prolactin uh, investigation. Now, how this prolactin affects? So the prolactin, we all know prolactin negatively modulates the secretion of the pituitary hormones, which are responsible for gonadal function. Because we know pituitary controls the gonadal ovaries, including luteinizing hormone and follicle stimulating hormone. So we measure prolactin. What about the insulin level? It is not suggested in all patients, but it is suggested in obese patient, especially when the anovulatory PCOS or resistant PCOS or hyperandrogenic PCOS. So we will differentiate how to differentiate between this. You can say resistant PCOS from other PCOS. So basically, you must understand the phenotypic classification of the PCOS based on hyperandrogenism, anovulation, and PCO-like arrangement, PCOM. So if all three features are present, then it's a classical phenotype A PCOS. If only anovulation and hyperandrogenism is present, then it is a phenotype B. That also falls in the resistant PCOS, or you can say severe PCOS. But type C, where hyperandrogenism is not there, hyperandrogenism with PCOM, then it is a phenotype C. And D is without hyperandrogenism, only PCOM and anovulation. Then it is a phenotype D. So these C and D are milder type of PCOS. They are not a resistant PCOS, but A and B are resistant PCOS. So if any case of resistant PCOS or phenotype A or B, A and B, where the AMH is more than 9, we must advise insulin level So fasting level, the fasting level cutoff is 19 microunits per ml, and postprandial is 41 microunits per ml. So if anything within this range is absolutely fine. What about the testosterone level? The normal level on day 3 is between 20 to 60 nanogram per deciliter. It has been observed that day 3 testosterone level, which is lesser than 20 nanogram, were 5 times less likely to achieve pregnancy, because testosterone or androgen is very, very important for the recruitment of the uh, uh, FSH independent follicle. For FSH independent follicular recruitment, the androgens are very, very important. That plays a very important role. Not only that, it increases the follicular sensitivity towards FSH. So better recruitment happens if the androgens levels are normal. So higher level suggests chemical hyperandrogenism, and if the levels are lower, possibly these are the right case where the androgen supplementation probably can help. Now, something about ovarian reserve. When we are measuring ovarian reserve, we measure enteral follicle count. But the transvaginal, it should be measured, it should be done with the transvaginal probe, uh, preferably with this at least 9 megahertz probe. The problem with the enteral follicle count is we count atretic follicles also. So sometimes that gives a false idea about the the ovarian reserve. And normally the enteral follicle count are dependent on the primordial follicle pull. So that represents directly the pull of the primordial follicle as discussed earlier. But if we find 2 to 5 millimeter follicles more, then we should be happy, because these are the follicle who have got ovulatory potential. We all know AMH is secreted by the granulosa cells of the preentral and enteral follicle. And there is no significant diurnal and cyclical variation. So AMH can be measured at any part of the cycle, so there is no problem. The normal level is considered 1.5 to 3.5 nanogram per ml. And obviously, with this result, why sometimes we are confused after getting the report, because this result varies between lab and detection method and assay method. So you have to find out the lab and standardization. CLIA method is the most standard method that gives a fair, very good, reliable report. Then what is the clinical significance? If AMH is very, very high, more than 9, 10, then that signifies the phenotypical classification A and B. And in such patient, the weight loss impact on ovulation is not remarkable. So if the patient has got very high AMH and if she loses weight, there is not necessarily the cycle should get regular. The ovulation may not happen with a little weight loss. The PCO drilling effect is also not remarkable if the AMH is very, very high. So these PCOS are called resistant PCOS, especially when the AMH is more than 8.58, and they are resistant to be stimulated by oral drugs like letrozole and clomiphene. And these patients most likely, they require gonadotropin for the stimulation. Not only that, these PCOS are considered to be a poor responder PCOS when you're stimulating them with the gonadotropin in IVF cycle. So these PCOS may require little higher dose of gonadotropin as compared to other phenotypic PCOS. What is the role of AMH in unexplained infertility? Uh, Luckily, there is no much role of AMH. If the patient is of unexplained infertility, suppose there are two patients. One patient has got say AMH 2 and another patient who has got AMH 2.5. third patient, the AMH is 1.7. The fertility is not different, and clinical pregnancy rate is not different. So in unexplained fertility, variation in the AMH does not play any important role for what has been concluded. What about the IUI results? If the AMH, it has been observed that if the AMH is less than 2, then IUI results are compromised. So ovarian reserve is very, very important for IUI results. The AMH gives a fair idea about chances of pregnancy, little better idea about the chances of pregnancy compared to AFC. The quality of the oocytes are assumed in little better way as compared to the enteral follicle count. Follicle output rate is also uh, presumed little in a better way. Blastocyst rate is higher if the AMH level is good. EPROD rate is also observed higher if the AMH values are higher, but within normal range. But what happens if there is a discordant value? What do you mean by discordant value? The enteral follicle count is less and AMH is higher. Then will you believe to the enteral follicle count? Will you believe to the AMH? It has been observed that if there is values discordant, especially in diminished ovarian reserve, you should rely more on AMH rather than AFC as far as the follicle output rate or maybe quality of those sites or chances of pregnancy, blastocyst rate is concerned. Coming to the semen related problem. Normally, we all know WHO criteria, but we pay more attention immediately on sperm density. And if the sperm density is less than 15 million, then we definitely consider it as a oligospermia. Then after count, we pay attention on the progressive motility. If the progressive motility is less than 32%, then we consider it as oligospermia. And if the count is very, very low, then definitely we pay attention on the fructose test, whether fructose test is positive, negative, because fructose test is, if it is negative, then it is suggestive of obstructive azoospermia. Similarly, the pH of the semen is acidic. Can you mute, please? Somebody has unmuted the mic. Please, can you mute? So the pH and fructose test is very, very important in severe oligospermia or azoospermia. Now, how do you anticipate the uterus-related problem? Very simple. If the patient has got some menstrual abnormality, like heavy periods, scanty period, intermenstrual bleeding, and after doing sonography, the diagnosis becomes absolutely clear. If any problem related to uterus or endometrial cavity, or then you definitely will come to know. But the patient, you should make it very clear to the patient that tubal problems are not easily detectable by transvaginal sonography and clinical examination. So always explain the patient that you now, after examination and investigation, uh, uh, we have got fair idea about everything except fallopian tube, because in fallopian tube, the health of the fallopian tube and patency of the fallopian tube, anatomical patency as well as the physiological functional capacity of the fallopian tube, both are very, very important. And there are certain, none of this is detectable by transvaginal sonography. So this patient requires a specialized test. This should be emphasized at first investigation or first consultation only. Now, how do you anticipate tubal problem? So if the patient gives history of dysmenorrhea, dyspareunia, lower abdominal pain with the leukorrhea, you should always keep tubal problem in mind. there are many patients who gives history of any abdominal surgery and tuberculosis, especially during childhood. So in such patient, you must anticipate tubal problem. And if you're doing transvaginal sonography, if you find such type of the picture, then you should anticipate tubal problem, like increased vascularity, especially subserosal vascularity of the uterus. There is a free fluid in the pouch of Douglas, maybe non-homogeneous endometrial echo. The ovaries may be displaced because of the pushing or pulling by the adhesions, or the hydrosalpinx is easily or detectable sonographically. So if you get such type of the sonographic picture, then that clinches the diagnosis towards the tubal problem. When do you suspect endometriosis? Again, patient gives a history of dysmenorrhea, dyspareunia, or abdominal pain. If you do a transvaginal sonography, if you find any of such changes, then definitely you should suspect endometriosis, like changes of adenomyosis. Now, how do you diagnose adenomyosis? There is a asymmetry between the myometrial thickness, sunray appearance, maybe subendometrial cyst seen, uh, non-homogeneous echogenicity of the myometrium. Then will be a focal swelling or globular swelling of the overall uterus. So that gives an idea about the adenomyosis. And adenomyosis, if there is a pelvic endometriosis, the adenomyosis is normally on the posterior one. So if you get such changes, then that clinches the diagnosis of endometriosis. Endometriosis and adenomyosis are associated in approximately 90% of the cases. Endometriotic cyst, obviously, it's very easy to diagnose by sonography. Fine granular echoes are seen. Now, if you carefully doing transvaginal sonography, you will come to know if there is a mobility restriction in the uterus, the probe is not gliding well. So you come to know that something wrong with the mobility. The ovaries may be displaced, as I said earlier, because of the pushing or pulling. And in all cases of endometriosis, there is some amount of the free fluid always left in the pouch of Douglas. Because endometriosis is a disease where a lot of cytokines are present in the peritoneal cavity, and that keeps irritating the peritoneum. And there is always some free fluid in the pouch of Douglas all the time, all across the cycle length. Now, everything has been done, and still you are not able to find out anything which is obviously not, obviously abnormal. Then probably you are dealing with the unexplained infertility. So you've done ovulatory function test, you've done tubal patency, you've tested tubal patency, you've done transvaginal sonography, and you've done semen analysis, but you're not able to find out anything. I'm sorry, the tubal patency will come little later, because at first go we do not do tubal patency, but at least there is no finding which suggests that tubal problems may be anticipated, which has been discussed later earlier. So if you do not anticipate any tubal problem or any uterine problem, or male part is absolutely fine and cycles are absolutely regular, then probably you are dealing with the unexplained infertility. So first step is decide what is probably you are dealing with, what type of the infertility, what is a probable factor. Now, second decision, important decision to be taken, clinical decision, is to decide whether you want to do a tubal evaluation urgently or not, because that is very, very crucial decision. You cannot have stereotype fixed decision. Okay, all the patients who are coming to you for the first time in the consultation, you advise for HSG or you advise for laparoscopy. No, that's unfair. So what is a group of the patient where the tubal evaluation should be done urgently, immediately? So if the couple is elderly, with the wife more than 30 years of age, they're married more than 2 years, uh, uh, because they have, instead of trying 1 year, they have tried 2 years, because they have taken full advantage of spontaneous chances of conception, chances of spontaneous conception, still they have not, C is not conceived. You have any suspicious of tubal factor? We have discussed how can you be suspicious about the tubal factor. The transvaginal sonography is suggestive of either endometriosis or PID. And last but not the least, the couple who are wanting a fast track step up treatment, like they immediately, if nothing, if oral tablets, oral drugs are not working, they want to step up immediately gonadotropin, or directly they want to step up gonadotropin. If that's not working, they want to start directly want to go for IUI for 3 cycle, or maybe that is not working, they want to go for IVF. So the couple fast track treatment who want to take a fast decision, then this tubal evaluation should be done earlier, because then and then you can ensure them that you are not going to waste a precious time of such fast track couple. In which case the tubal evaluation is not urgent. The young couple who is less than 2 years of married life, active married life, there is no suspicions of tubal factor either by clinical examination, history, or transvaginal sonography. And the couple who are not wanting a fast track treatment, they are okay with the standard. They are not. They are at ease, and they are okay with the standard type of treatment. They do not want to go fast. They do not want to spend too much, but they want ideal standard treatment. Then tubal evaluation at first go is not urgent, not mandatory. Now, third decision we want to take is whether we should advise laparoscopy, hysteroscopy diagnostic now only, immediately only. That is a decision, important decision to be taken. So, what are those cases where you need to advise laparoscopy immediately? So, the first scenario is the tubal blockage, which is suspected by other tubal evaluation method, like sonosalpingo, hysterography, or maybe HSG or SSG, whatever, that is suggestive of some tubal blockage. So that's first scenario. Second, the fast track couple who are wanting to complete the evaluation before deciding the final treatment. The patient typically says, डॉक्टर जो भी आप करना है कर लो, हम आप डिसाइड करके दो हमको क्या करना है, हमको राह देखना है, आईयूआई करना है, आईवीएफ करना है, हमको जल्दी से बच्चा चाहिए. So such type of the fast track couple, then laparoscopy, hysteroscopy should be done, because that only gives a fair, I would say, the best idea about the fertility treatment, because this is the only way to find out the tubal health, the physiologic, and that is suggestive, that gives a fair idea about the physiological function of the fallopian tube. So this you get by laparoscopy only. Now, if the patient has got mild to moderate endometriosis, sometimes you miss on transvaginal sonography. So laparoscopy is the gold standard method of diagnosing the missed cases of endometriosis. So in all fast track couple, laparoscopy and hysteroscopy should be advised at first go only. Third category is elderly patient who are having unexplained fertility. So you are not able to find out any reason, and the age is already advanced, but still the patient has got acceptable ovarian reserve. Say, for example, the AMH is 1.5, 1.4, 1.6, something like this. And same time, they are not affording for IVF. They are requesting you to try, doctor, something other than IVF treatment. So these are the typical group of the patient where you should go for laparoscopy before giving them verdict of not going IVF, but to try other treatment. The fourth group of patient is obviously very easy to understand, for the removal of the fibroid, polyp, adhesions, endometriotic cyst, correction of the shape abnormality when it is indicated. So obviously you have to do this. The fifth group is when there is a suspicion of mild to moderate endometriosis. So you are suspected, okay, patient may be having endometriosis because she gives typical history of dysmenorrhea, dyspareunia, the mobility is restricted on transvaginal sonography. There is some element of adenomyosis, some free fluid is there, some small chocolate cyst is also there. So such type of the patient, but they want to try a non-IVF treatment fully before jumping to the IVF, or they are not affording for IVF. So in mild to moderate endometriosis, who are not symptomatic, or maybe you can say milder symptomatic, uh, uh, with adequate acceptable ovarian reserve, and they do not want to try IVF or they are not affording for IVF, then you must do a laparoscopy, histoscopy. Because if you do a laparoscopy, histoscopy, and do the cauterization, fulguration, remove the adhesion, cut the adhesions, and restore the tubal ovarian relationship, the chances of spontaneous conception is increased tremendously. Not only that, you are by doing laparoscopic treatment, surgical treatment, you are uh, downgrading the endometriosis. So if it was a severe grade, it becomes moderate grade. If it was moderate, it becomes mild. And if it is a milder endometriosis, then it becomes like unexplained infertility for all practical purpose. So in such patient, you must do laparoscopy. And last but not the least, severe PCOS, which is resistant to oral drug. What is the advantage? Because this patient requires gonadotropin injection. Now, before giving gonadotropin injection, suppose patient wants to try that, do something, doctor, and make sure that this is going to work. So you would like to assess the tubal health, and laparoscopy is the best way. And simultaneously, you get a chance to do PCO drilling. Of course, it is not PCO drilling should be done in a very conservative way, not 3 to 4, not more than 4 punctures should be done with a typical setting, but definitely it helps and it reduces the gonadotropin requirement. It makes the stimulation little easier. So these are the patients where laparoscopy and hysteroscopy should be advised at first go only. Now, next decision we take is which are the group of the patient where expectant treatment with or without some additional medicine is should be done before jumping to a controlled ovarian stimulation, either time intercourse or IUI, or maybe controlled ovarian hyperstimulation with IVF. So, if there is a medical disorder which you found out, like thyroid problem or hyperprolactinemia or diabetes or hypertension, that should be absolutely treated first before jumping to the treatment. All young couples, active marriage life less than 3 years, who are okay, they do not want fast track treatment, and the patient who are having, you're suspecting unexplained infertility. So unexplained infertility, young couple, active marriage life less than 3 years, non-fast track couple. So they must be offer a folic acid, zinc, B complex, vitamin D, antioxidants for at least 2 months. Because according to very recent study, the folic acid supplementation more than 1200 microgram is very, very important, and it tremendously increases the chances of spontaneous conception. And this folic acid, which is achieved from the dietary supplementation diet from diet, is not useful. External supplementation is important. So all such patients first, they for 2 months they should be supplemented, and to vitamin D deficiency is also very plays very important role. And along with that, if you provide antioxidant, that also corrects the oxidative stress. So all such couple should be pre-treated, I would say pre-treated before starting active treatment. Third group of the patient is all obese PCOS, who are insulin resistant young couple, active marriage life less than 3 years, non-fast track. They should be offered weight loss program, insulin sensitizer, and micronutrients, so that your stimulation becomes easier. They do not fall into severe PCOS, and there you might improvise the oocyte quality. But this is ideal for young couple, non-fast track couple, and who are not in a hurry. So this should be pre-treated with weight reduction and micronutrients, of course, with dietary modification also. All patients of diminished ovarian reserve, especially their AMH is decent, not very less, like more than 1 nanogram. They should be pre-treated with the antioxidants and androgens for 2 months before starting active treatment. The husband subnormal semen uh, uh, where there is a medical treatment is indicated to improvise the semen parameter, including DNA fragmentation. They should be treated for 3 months. So suppose the patient has got repeated miscarriage, or and you treated her for him for DNA fragmentation. If you found DNA fragmentation, then you must treat for 3 months by the antioxidants. Uh, apart from if the semen is mildly compromised, we would like to uh, you know give certain empirical treatment which may help, may not help, but we would like to try for a couple of months. The laparoscopically treated mild endometriosis with the normal tubes and semen in especially young patient, non-fast track treatment, because simply this patient becomes now unexplained infertility, and their marriage life is less than 3 years. So you would like to give some chances of spontaneous conception, then you may treat expectantly. Very interestingly, it was observed during one study that in the patient who were waiting for IVF in unexplained having unexplained infertility, what they observed while waiting period, 27% of the patient they conceive spontaneously. So in unexplained infertility, there are very high chances of spontaneous conception. You must give a fair trial of giving spontaneous conception. And last but not the least, you should take care of local vaginal and cervical problem. So these are the group of the patient where you can offer expectant treatment before jumping to a very active treatment. Now, the first active treatment is not actually active, but you can say self-monitoring of the cycle with the time intercourse. So before advising the patient self-monitoring, you have to educate them how ovulation happens, what are the important days, and all physiology of the menstrual cycle and conception you should explain to them. So that if the couple is young patient with the regular cycle, believe, I'm again telling you, regular cycle. Young couple with the regular cycle, unexplained infertility, or treated pathology who are not willing for active treatment. कपल से कि डॉक्टर पहले ट्राई तो हमने किया ही नहीं, ज्यादा हमको ट्राई करने दो, ठीक है, हमको एंडोमेट्रियोसिस था या कुछ XYZ प्रॉब्लम था, सिस्ट थी या पोलिप था, वो आपने ठीक कर लिया है, नाउ वी वांट टू ट्राई बाय आवर ओन. So those who are not willing for active treatment, or those who are recently married, anxious couple, still they have married since 6 months only, young couple, but they are anxious for conception because there was some history of infertility in any of the family members, so they are quite anxious. So in such patient, you can advise self-monitoring with the time intercourse. So how the self-monitoring is done? You should teach them how to monitor the cycle with the mobile application, Urinary LH Kit, and Inito monitor. That's another type of strip which take into account estradiol level, progesterone, and LH combined, and that gives a very good idea about the fertile period. So, few words about the Urinary Detection Ls Kit. This should be done ideally early morning. It's preferred because the LS surge typically begins early in the day, and the urine is the most concentrated at this time. So the patient must do it in the early morning only. It has been observed that in 90% of the cycle, the LS search is identified, and the results are correct because it was confirmed by BBT in 99% of the cycle. So the correlation between urinary and serum LH was also found good. What is a detection level? The lowest level which was detected as positive by LH kit, which was ranging from 25 to 50 units depending on the manufacturer. So this is the sensitivity of the LH kit. The follicular collapse was noticed in majority of the 24 hours of detection of the urine and maximum 48 hours. So if the LH kit detects LH surge, next 48 hours are important or crucial, you can say, for the ovulation, and that's the most fertile period. There is a more accuracy with LH kit than BBT and progesterone measurement for impending ovulation, according to one study. So I would say collectively that urinary LH kit is a very good idea, even if you are doing control ovarian simulation with self-monitoring or time intercourse or IUI, you must incorporate urinary LH kit into your treatment. That is going to enhance uh, your accuracy about the various judgments or various decisions which you're going to take. Now, second modality of the treatment is control ovarian stimulation with the time intercourse. So, what are these patients where you would advise this treatment? The patient having irregular cycle, like PCOS. The couple is young, less than 3 years of marriage life, and doesn't want fast track treatment. Then maybe mild or no endometriosis. Tubes must be normal and semen analysis should be normal. So male partner should be okay. Fallopian tube should be normal. There should not be any endometriosis, severe endometriosis. Couples should be young, less than 3 years of marriage life, and mostly anovulatory couples, anovulatory patients. So for them, the control ovarian stimulation with time intercourse is the ideal treatment. It should be tried approximately for 6 cycles before jumping to the next step. What about the control ovarian stimulation with the IUI? What are the correct indications of this treatment? Because I have seen in most of the center, they consider IUI either as a second step treatment after time intercourse or just pre-treatment before jumping to the IVF. That is not a fair. You must know what are the exact indications where you should offer IUI at first go only. So those couple who are having mild male factor. What do you mean by mild male factor? The sperm concentration is 5 to 10 million, and there is a compromised motility, asthenospermia. So there you should advise IUI at first go only. If there is, you are suspecting any cervical factor, is there any ejaculatory disorder, or the patient is having unexplained fertility as a in unexplained fertility, the IUI gives little better result as compared to the time intercourse. So you can advise IUI as a first go treatment, primary treatment, or you can step up from the expectant or time intercourse treatment. In PCOS, yes, if the time intercourse has not worked, semen analysis is normal. If you advise, step up for IUI, then results are a little bit improvised in PCOS. Uh, and last but not the least, the treated endometriosis case or operated endometriotic cyst with normal tubes, ovarian reserve, especially in young couple who are less than 3 years of marriage life and non-fast treatment. So these are the group of the patients where the control ovarian stimulation with IUI should be advised. Now, when we are doing ovulation, control ovarian stimulation, or you can say ovulation induction, what are our purpose? We want to correct the anovulation or oligoovulation. We want to recruit any additional follicle which is going to enhance the chances of conception. We want to make sure that the growth of the follicle, recruited follicle, is uninterrupted. We want to see that it reaches to the ovulation. We want to advise the time intercourse or in IUI according to during the peri-ovulatory period. And Once making sure that OC has ovulated, we want to provide a luteal support after ovulation in most cases. So these are the purpose of ovulation induction. Now, uh, what is the choice of stimulation in non-ART? How decision whether to go for oral drugs, whether to go for gonadotropin. Uh, so how such decision to be taken? So overall, looking at the overall experience, overall evidence, gonadotropin by far, gonadotropin stimulation is either superior or at least non-inferior to oral drugs in all patients. But you have to understand that it comes with a price tag. There is increased multiple pregnancy rate and increased chances of uterine hyperstimulation syndrome. So you have to be very judicious when you're using gonadotropin for non-IVF treatment. But it is distinctly superior in all spectrums of the patient. May it be mild male factor, may it be mild tubal factor, may it be PCOS, may it be unexplained infertility. Gonadotropin is distinctly superior. In unexplained fertility, where you letrozole CC both gives almost equal success rate, they can be combined with the gonadotropin or they can be singularly can be used. But normally in unexplained infertility, you wish to have one extra follicle, multifollicular development. So preference is should be given always to the CC with without gonadotropin or only gonadotropin. If the patient is milder PCOS, then obviously letrozole with or without adjuvant. If there is insulin resistant, obviously insulin sensitizer you give. So letrozole is should be the first drug of choice. But same is not true when there is a severe PCOS. If, as we discussed earlier, the cases of severe PCOS require gonadotropin addition or directly gonadotropin. So letrozole with gonadotropin is the right choice. Or if the patient is affording or letrozole on gonadotropin, you are not able to titrate properly, then chronic low dose step up gonadotropin stimulation is the ideal, and that gives the best chances of conception in severe PCOS. And your goal is not to have more than one or two follicle, and that purpose is served well when you're doing chronic low dose step up protocol. But you and your patient need to have adequate patients and adequate funds for chronic step up low dose gonadotropin stimulation. Now, what is the total motile sperm count is required when you advise for IUI treatment? So if it is raw sample, then 5 to 10 million per ml is adequate for successful IUI. But if you look at the sperm count in the inseminate sample, minimum 1 million sperms are required in inseminate sample. Normally, our inseminate sample is 0.4, 0.5, 0.6 ml. So in that that much fluid, 1 million sperms should be at least present. Now, the final treatment is control ovarian hyperstimulation, where you want to advise advanced ART treatment. So what are those group of patients where you at first go only you would advise for IVF treatment? So the patient having distal tubal block. Distal tubal blocks are not easily amenable. Even it is corrected laparoscopically, the success rate is not increased, and most of the time it is a wastage of time and money. But same is not true when there is a proximal tubal block. Proximal tubal block, if it is a milder type of block, with the histoscopic cannulation, it is corrected, and many patients conceive after the cannulation. But within 1 year, approximately 50% of the cannulated cases fail. Or in many times, if there is a ischemica nodosa salpingitis, then cannulation is impossible. And suppose you have done cannulation and tried other treatment like time intercourse or IUI, depending on the sperm uh, count. After 1 year, if uh, After corrective tubal surgery, if she has not conceived, then this patient should be advised for IVF without any further delay. All patients of severe PCOS who are not responding to the average dose of gonadotropin. Suppose she needs a very high dose of gonadotropin, almost similar 2000 to 2500 international unit in whole stimulation. Then there is no point in spending for a treatment where barely gives success rate 10, 12, 15%. Instead, she should be advised to go for IVF, where only you can assure them a conception after one stimulation only, because after one stimulation you're going to get at least 15, 20, 25 embryos. So which should absolutely suffice to make her pregnant. So in severe PCOS, where gonadotropin requirement is high, you should advise for IVF. In the cases of severe endometriosis, which especially when affecting a tubo-ovarian relationship, diminished ovarian reserve, the severe endometriosis with diminished ovarian reserve, or patient is elderly, or the patient is having bilateral endometrioma, bilateral chocolate cyst, or the patient has got recurrent endometrioma. So these are the cases of endometriosis which needs IVF immediately. I'm repeating, severe endometriosis with tubo-ovarian relationship is disturbed. There is associated factor like diminished ovarian reserve, or the patient is advanced age, bilateral endometrioma, and recurrent endometrioma. So IVF is the treatment. Donor oocytes, undoubtedly, surrogacy, undoubtedly, because there is no alternative. You have to go for IVF because we need a macro manipulation, PGT. So in all three cases, undoubtedly, you have to advise IVF only, that because there is no option. You have tried all control ovarian stimulation with time intercourse, IUI, and there is a failed non-IVF treatment, then you have to advise for IVF. You can advise IVF as a primary or step up from IUI in fast track couple. Suppose patient wants, no, doctor, it's all right. You said that IUI can work in my case, time intercourse can work in my case, but I do not want to go for that. I want to become pregnant within 2, 3 months only. Give me the best treatment, the most successful treatment. So you have to advise IVF. There is no option. You cannot say that no, you have to go through the standard step only. No, it's not required. Severe oligospermia, where the count is less than 5 million per ml on different two occasions, IVF should be advised after making it sure that it is definitely such a severe oligospermia. And when you are planning to use testicular sperm, you have to go for IVF. So these are the different indications where you have to go for advanced ART like IVF. Now, when we are planning to go for IVF, which are the cases where you would go for milder stimulation? Next decision whether to go for milder stimulation or what do you mean by milder stimulation? Milder stimulation means you are combining oral ovulogen with gonadotropin, which is not exceeding 150 units every day. So this patient, in other words, you want to take the advantage of native or patient's own FSH, which is secreted at the beginning of the cycle, because there is a difference between native FSH and externally supplemented FSH gonadotropin. The native gonadotropin is always better, and because the for some reason you have decided to go for milder stimulation, you want to start with the oral ovulations. So what are those group of patients? The Poseidon group 4, where the patient is of advanced age and ovarian reserve is also reduced. So you're not going to get, it's a tired horse, you're not going to get by hitting more. So your intention is to, instead of that, your intention is to have repeated cycle and accumulation of the embryo before starting transfer cycle. The second group of patient is couple who want fresh transfer only. Suppose patient has come from Indian couple come from USA, and they want to just finish it off within 1 month. They want to try IVF. And so obviously you cannot go for freezing cycle. So if you intend to do a fresh cycle, then it should be always a milder stimulation cycle. The patient of breast malignancy or thrombophilia, where you do not want very high estradiol level, so where you should go for milder stimulation. And as per the latest ART Act, the donor stimulation should be always milder. You should not retire more than 7 oocytes, and at no cost, she should suffer from ovarian hyperstimulation syndrome. Now, these 3 or 4 slides are very, very interesting and important, and you must remember all your confusion regarding the management of the endometriosis will be clear. How to manage mild endometriosis, how to take decisions of milder endometriosis. So, milder endometriosis with no other factor, only milder endometriosis is there. And there is no other factor like patient is young, the ovarian reserve is adequate, tubes are good, and there is no semen compromise, only mild endometriosis. So in such patient, suppose this was found during laparoscopy, it should be corrected. And after correction, IUI should be offered because the best chances of conception you are getting in next 3 to 6 months. But if you have not done laparoscopy and here you have just presumed that she has got milder endometriosis, control ovarian stimulation with IUI 4 to 6 cycles should be tried because IUI gives better result in endometriosis and unexplained infertility. So if these IUI cycles are unsuccessful, go for IVF. And when you're going for IVF, long agonist protocol is preferable with fresh transfer or if there is some element of the adenomyosis, you should always prefer a frozen embryo transfer cycle after agonist downregulation. So FET cycle should be done after agonist downregulation only. So this is about the mild endometriosis with no factor. But if there are coexisting factors like age more than 35, diminished ovarian reserve, affected tube, severe oligospermia, you should always advise for going for directly IVF. What about the severe endometriosis? So if most of the severe endometriosis patients are symptomatic patient. So if the symptomatic severe endometriosis patient without other factor, no other problem, then operative correction is advised because symptomatic patients require surgical treatment. So operative correction of peritoneal disease. If you correct the peritoneal disease, the symptoms are resolved and followed by control ovarian stimulation with IUI for 4 cycle. If that is successful, fine. If it is not successful, advise them step up IVF. Second, symptomatic severe endometriosis, if there is a coexistent other factors, operative correction because the patient is symptomatic and followed by IVF immediately. Third group of the patient, symptomatic severe endometriosis with coexisting endometrioma. If the size of the endometrioma is more than 3 centimeter, or if you think that the follicles are not accessible when IVF is required, then you should operate on them, surgical resection, and followed by IVF. But if the endometrioma is less than 3 centimeter, if no peritoneal lesion suspected or surgically suspected, then that is one scenario. And second, surgically corrected 3 centimeter symptomatic endometrioma you have corrected, IUI can be tried before IVF. And fourth, if there is an involvement of the ureter or bowel, surgical correction followed by IVF is advised. Now, fifth group of patients, when there is a severe endometriosis and recurrent implantation failure, this patient must be subjected to the operative correction, but it should be a multidisciplinary approach. And after that, the IVF or transfer should be tried. And sixth group of the patient, bilateral or recurrent endometrioma, which we have already discussed, these patients should go for IVF directly. Now, few words about the sclerotherapy. This is very, very good treatment, especially in symptomatic women and who plan to conceive. but who having a low ovarian reserve. So basically, diminished ovarian reserve in symptomatic endometriosis. This is very good treatment in which we inject sclerosing agent into the cyst cavity, and which can be either removed or retained fully or partially within the cyst. It is done a transvaginal sonography. What it does, that causes disruption of the cyst epithelial lining with a subsequent inflammation and fibrosis that will eventually result in obliteration of the cyst. The clinical pregnancy rate in cystectomy and this sclerotherapy are similar. Very important point to be noted. Although the oocyte retrieval rate was higher in sclerotherapy. Oocytes, you get more oocytes in following sclerotherapy. What about the recurrence rate? Cystectomy has the least recurrence rate, followed by sclerotherapy with the retention of the sclerosing agent, followed by sclerotherapy with non-retention of the agent, and the highest recurrence rate is if you do only aspiration. What about the antral follicle count and AMH? That increases after sclerotherapy due to mechanical decompression and improved vascularization. The side effects are very mild abdominal pain and transient fever, which is easily manageable. So, in non-symptomatic cyst, outcome is not improved with the IVF. So, you may think that, okay, this is a very good treatment. Let us try with when there is a ovarian cyst, a recurrent ovarian cyst. Please do not try if it is not endometriotic cyst. Now, what about the male endocrine evaluation of the infertile male? What investigations are required? So, till now we discussed a female partner. Now we are discussing male partner. So, endocrine evaluation of the infertile male is indicated if the oligospermia less than 10 million sperms per ml. What are the investigation? FSH and testosterone must. LH is indicated when a testosterone value is less than 300 nanogram, and prolactin when hypo or there is a decreased libido, and serum estradiol is indicated in obese patient. When do you advise for testicular biopsy in male? When you are not certain and there is uncertainty whether obstructive or non-obstructive azoospermia is there. So what are these cases? Where normal or near normal segment volume is there, testicular volume is normal, at least one palpable vas deferens is there, and FSH is borderline in the range of 9, 10, 11, 12, 13, something like this. The simultaneous sperm cryopreservation has to be planned if possible, because that's a golden opportunity you get. What imaging, when do you advise imaging study in case of male? So the scrotal ultrasound are not done routinely, provided clinical examination is normal. But if it is not normal, then you must advise scrotal ultrasound. Transrectal ultrasound is advised when semen analysis is suggestive of ejaculatory duct obstruction. How do you suspect? By acidic pH, azoospermia, and semen volume less than 1.5 ml. Normal serum testosterone and with the palpable vas. So this is a typical scenario where you suspect ejaculatory duct obstruction. Renal sonography is advised when vessel agenesis is found out. Basically, it is to evaluate renal abnormalities which are commonly associated with this. What about the empirical therapies for male factor infertility? So the medical therapy for idiopathic male fertility moderately effective, but there is no clear predictor which patient is going to respond. What do you give? We give CC 25 milligram plus vitamin E 400. In one of the trial, it was found good improvement in the quality and pregnancy rate, but not known it was because of the vitamin E antioxidant effect or what. Of course, the Cochrane reviews failed to support the use of CC in oligosteroteratospalmia. The male with the low testosterone to estradiol ratio is benefited by anastrozole, or you can say letrozole, but in the absence of underlying endocrinopathy, it is not effective. FSH, what about the FSH in idiopathic male infertility? It was found effective in systemic review of 6 RCT, although the quality of the evidence was moderate. So you can, patient is affording, you can go for CC plus FSH. If the, in some of the patient, you may get the benefit. The SCG is effective, especially when there is a hypo or serum testosterone level is less. The several studies found correlation between blood concentration of the micronutrients and sperm quality, but effect on increasing live birth rate is not conclusive. The low testosterone level, aromatase inhibitor, CC, SCG, or combination is useful. Antioxidants, vitamin have questionable role. Limited data supporting the medical treatment in the form of CCAI or gonadotropin prior to surgical intervention. So prior to testicular aspiration, this pre-treatment is important and it may enhance the chances of retrieving the sperm. How do you treat hypo? You first start with the SCG, and once the testosterone level becomes normal, the FSH is added for optimal spermatogenesis. This is how you should treat male hypo. When there is a decreased libido, with or without importance, the testosterone deficiency with low LH warrants serum prolactin measurement, which we have already tested. And if you find any abnormality, you have to treat. After non-obstructive azoospermia treatment, hormonal treatment after non-obstructive azoospermia increases the chances of retrieval, as we discussed. When do you predict the chances of successful sperm retrieval by TESA in non-obstructive azoospermia? When the testis size is more than 7.75 ml and FSH is less than 8.5, there are fair chances of retrieval by TESA. But if more than 24 unit FSH and size less than 6 ml, have only 7% probability of finding sperm in TESA. But if you do TESE, the chances are little more. What is the impact of histopathology on prediction? If the histopathology report is hypospermatogenesis, there are 52% chances, the highest chances of retrieving sperm. If the HP report is showing maturational arrest, then 36%. And if the report is showing Sertoli cells only, then chances are 12%. And if the HP report is showing tubular atrophy, then 0% chances of retrieving sperm by surgical retrievals of the sperm. What about the varicocele? If there is a infertility, palpable varicocele, and the sperm parameters are abnormal, the varicocele operation is advised. But in non-obstructive azoospermia with varicocele, there is no definite evidence. But if the testicular volume is less, there is a benefit of varicocele ligation. DNA fragmentation is done when there is a clinical varicocele or unexplained infertility, IUI failure, repeated pregnancy loss, IVF and ICSI failure. So in such patient, DNA fragmentation can be advised. Now, last 2 or 3 slides. When you're doing IVF, and if the patient is normal responder, then how do you go about IVF stimulation? So if it is a donor IVF, you are stimulating donor, then you should use antagonist protocol. You should use agonist trigger. There is 100% confirmed. You should use antagonist protocol and agonist trigger because you cannot afford to have any complication with donor. But if it is a self cycle, and if the patient wants a fresh transfer, or if there is a possibility of the fresh transfer because the previous cycle has shown good endometrium and everything fine, then ideally long agonist protocol should be used. But if you're planning for freeze all, then antagonist protocol can be used. If you're planning for back-to-back cycle, then antagonist protocol is better than long agonist protocol if you're planning for back-to-back cycle. But if the couple is fussy about the number of the injection and wants fresh transfer only, then you have to go for multi-stimulation protocol. So this is about the normal responder IVF. What about the hyper responder like PCOS? If patient is not keen for fresh transfer, antagonist protocol, agonist trigger. Patient is planning fresh transfer, then milder stimulation protocol should be used if with the smaller dose of SCG trigger. But in all such hyper responder, metformin treatment should be pre-treated. Patient should be pre-treated for 2 months before starting stimulation with the metformin, and it can be stopped once the stimulation is over, and that reduces the chances of OHSS, and that improves the oocyte quality. Now, regarding the Posidone group 1, 2, 3, 4, Posidone group 1 and 2 are having adequate ovarian reserve, and 3 and 4 they have got reduced ovarian reserve. The 1 is younger, 1 and 3 are younger. So, how do you treat Posidone group 1? So, in first stimulation, because you do not know, in Posidone group 1, after stimulation, you come to know that the response was suboptimal. So, in first stimulation, when the suboptimal response is noted on stimulation day 5, first you examine on stimulation day 5. So, the best option is to add recombinant LH activity 150 international unit daily, along with the increasing the dose of gonadotropin till maximum 450. That's the ideal thing to do. Second best option is to change over to HMG if it was started with the RFSH and make it 450. That's the second option. In all such patients, dual trigger should be used if it was antagonist protocol, otherwise recombinant SCG. This is index cycle. What about next stimulation cycle? In next stimulation cycle, add recombinant LH or recombinant SCG right from the beginning, along with the higher dose of recombinant FSH 450. So this is about the Posidone group 1. What about the Posidone group 2? Since the ovarian reserve is adequate, you want to stimulate hard, even if the ovarian reserve is less, because any single extra oocyte can make a change. So use standard antagonist or long agonist depot protocol. Starting dose of gonadotropin minimum 300 international unit. Letrozone can be added. You should incorporate RSCG 125 units from the beginning, along with the RFSH 300 unit, or you can start with the 300 to 450 unit of the HMG, because these are elderly patients, and in elderly patient, LH activity is very, very important. You may incorporate pyridostigmine or growth hormone, and in such patient, dual trigger if antagonist protocol, otherwise SCG. What about the Posidone group 3? In Posidone group 3, antagonist or long agonist depot protocol used HMG or RFSH, standard way, letrozole, pyridostigmine, everything is fine. There is an additional role of coenzyme Q10 in Posidone group 3, and androgen also plays a very important role. So testosterone gel in previous cycle for minimum 21 days should be advised in Posidone group 3. But if antagonist protocol is used, you can modify this protocol by making it luteal E2 antagonist protocol plus RSCG, adding LH activity before actual gonadotropin stimulation for 3 days before menses. So that gives good oocyte maturity, and it is found very useful. But if you, by doing this, if you retrieved less than 3 oocytes, then next stimulation protocol should be similar to Posidone group 4. Because in Posidone group 3, even though the patient is younger, their ovarian reserve, the patient is, their ovarian reserve is less, and patient, in spite of patient being young, their ovarian reserve is not adequate. So if by stimulating in a standard way, if she is not giving adequate response, then the next cycle should be a milder stimulation protocol. That is a stimulation of choice in Posidone group 4, because you want to do embryo pulling with the multiple stimulation. So milder stimulation or dual stimulation should be done. Incorporate oral drug like letrozole, testosterone gel in the previous cycle, androgenization of the cycle, pyridostigmine growth hormone can be used, recombinant LH and RSCGs from the beginning. And if the cycle is cancelled due to non-response, next time try Andro-IV protocol or CRER protocol. That is going to be useful in some of the cancel cycle in Posidone group 4. So the summary of the poor responder, standard protocol for all except group 4. LH activity for group 1, 2, 4, androgen for group 3 and 4, latrogen, growth hormone for all group, mild protocol or dual stimulation protocol for group 4, ultra long agonist is the best overall, followed by antagonist in standard protocol, and luteal into antagonist LH protocol is best for group 3. So this was all about the important decision which we are going to take during our infertility practice. Now, if you have any question, you could please feel free to ask.
Sir, I have one doubt. One of my patients, I have used chronic low dose stimulation protocol because she is lean PCO. I have given her 2.5 mg letrozole for 14 days and only single follicle developed. And now she conceived with IU at 10 weeks. So now should I give her metformin or not? Or should I do fasting and PLBS and then decide?
No. See, in Indian scenario, to give metformin, the documentation of the insulin resistance is not needed. So I prefer to, if you, anytime if I want to improvise the stimulation in PCOS, I always pre-treat with the metformin.
So, but during stimulation, we can give metformin. There is no harm, na, sir?
During stimulation, you can give metformin, but it should be well stopped before the end of the stimulation, because basically metformin, action of the metformin is through cyclic AMP, and cyclic AMP plays very important role in division, cell division. So there is a theoretical chances that if you continue with the metformin when there is a rapid division of the cells in the body, and if there is a remnant delayed effect of metformin, and possibly it might hamper the division of the cells in developing embryo. So I am not very keen on continuing metformin when stimulation is started.
And
Hello,
sir,
Yeah.
hello,
please
sir.
carry on.
Yes.
Sir, I have one question that you said LH kit, if you use and if it shows positive, so within 48 hours, it will show that ovulation has to be occur. So then there
Yes.
is no need of giving SCG, na?
There is no need to give SCG.
To prevent SCG.
There is no need to give SCG, but if you by chance if you give SCG, supposed to be on safer side, because there are two types of the conclusion. In one study, it has been said, it has been proved that if you override the LS surge by giving SCG, it improves the pregnancy rate. Another study having contradictory conclusions. They say that if the LH surge has occurred and if you give SCG, then it deteriorates the result. But the recent evidences are saying that even after LH surge, there is no harm in giving SCG trigger. So if you detect LH surge and if you give SCG trigger, there is no harm, but you should be very conscious. You should call the patient next day for the documentation of the next 2 days continuously for the documentation of the ovulation. And this decision is very important when you are doing IUI, because you would like to do IUI around ovulation. Na?
Yes.
That's the reason.
Okay, sir. Thank you, sir.
Sir, I have a query that my one patient, she is not having very good endometrium, but after down regulation, when I have started estrogen HRT cycle, only with the 2 milligram one TDS, that is 6 milligram, after 5 days, she has very thick endometrium. And it looks like hyperplasia near about 13 mm, and it is echogenic with some hypoechoic area. So should I go for a biopsy or what should I do now?
Say, I will make sure that there is no disturbance in androgen. Hyperandrogenism is not there. First, I'll make sure. Second thing, in such patient, what I would do, I will cancel the cycle and I will do premenstrual DNC sort of with the MR syringe because on OPD basis only. I would like to do the curating with the MR syringe, and after that, I would go for letrozole stimulation rather than going for HRT cycle. I would prefer to go for letrozole stimulation, stimulated cycle. What I mean to say.
Okay. Okay, sir. And then another query, sir. Then FTP.
Dr. Nina, do you have anybody has got any query? Let me see first. Just a minute. Let me see. No, nobody has. So please continue.
Just one query, sir.
Dr. Rekha, please.
The severe PCOS you had talked about, severe PCOS.
Yeah.
So, like, how will we diagnose whether we have already stimulated her then and found her to be not responding, or by LH and AMH?
No. Severe PCOS can be diagnosed by, you must do a phenotypic classification whenever you get a case of PCOS.
Okay.
Why? Because you want to know whether this patient is going to be benefited with the oral drug or not. That's the most important decision which you are going to take. So how do you classify? As I mentioned, classic PCOS is having hyperandrogenism, anovulation, and PCOM. So that is phenotype A. Phenotype B is anovulation and hyperandrogenism. And phenotype C is anovulation and PCOM. Anovulation and PCOM. No, sorry, hyperandrogenism and PCOM. And
Yes.
D is only anovulation and PCOS. So D is milder variety. Some cases of C are also milder variety. But when there is A and B, when there is a hyperandrogenism and anovulation is combined, then these are the severe PCOS. And in most of such cases, the AMH level is more than 9. It's more than 9. So if you get such type of patient, you have to use gonadotropin, or you should pre-treat such patient with the OC pills and metformin and then start stimulation.
Sir, one question. Sir, one question I have. Suppose a PCO patient is there. So should we use only FSH or HMG? What is the new guideline? Because previously they said in PCOS LH is more, so you should give only FSH.
Anything is fine because the LH activity provided by genuine LH activity provided by HMG is very, very minimal. And if the LH is already high in PCOS case, by stimulating it with the HMG, it is not going to increase LH level beyond a small, very small changes. It is going to make a little, very small changes. So it is not going to make any difference. What is important is when there is a LH level is high, your gonadotropin requirement is increased. So whether it is RFSH or HMG, it is not going to make any difference even in severe PCOS. It is a gonadotropin. You should consider it as, for all practical purpose, you should consider as a gonadotropin only. We are differentiating RFSH and HMG. Why? Because raw material is different. This is genetically engineered, and this is biologically derived from the urine. So the batch to batch consistency and other things are not there with the HMG, which is there with the RFSH. That's the only thing. If you really intend to provide a genuine LH activity, which is required in Poseidon group 1, 2, and 4, and all elderly patient, LH activity is must. There you should definitely actually add LH activity by small dose of SCG rather than considering HMG. Even if you're if you're stimulating with the HMG, you must provide a small LH activity by RSCG.
Okay. And sir, another thing I have to ask, during You said LH level on day 2, it should be less than 2. Sorry, less
Yes.
than 0.2. Sorry, less than 2. And during the trigger time, the LH level, how much should be there in antac cycle?
In both the scenario, if the LS level is more than 1, there is a fair chance of everything going smoothly. But if it is more than 2, you are assured. 1 to 2 is a little dicey situation. But if it is more than 2, you are sure.
Acha, means LH activity is there.
Yes.
Sir, I
Can
have
I
a query.
please last question, because my patients are waiting, because I scheduled up to 6:30 only, but because of some reason I am a little running late.
Yes.
So this is the last question, please.
Sir, in the modified natural cycle, should we give progesterone 12 hours more or the same like the embryonic age and endometrial age?
No, it's in modified natural cycle. Suppose you have documented ovulation, then if you use SCG trigger and you have documented ovulation, then I normally start progesterone maybe 48 to 72 hours after the SCG.
And the
And
total,
if it was a natural cycle where I have documented ovulation, then I start progesterone maybe 1 or 2 days before my transfer. But
oh,
the endometrial age starts from the ovulation.
okay, sir. Okay. Thank you,
Okay?
sir.
Okay. Thank you.
Yes, sir.
We
Thank
will
you,
meet
sir.
Thank you
next
very
week.
much.
Thank you. Yeah. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.
Yeah.
Thank you, sir.
Yeah. Yeah.